Yeah, we'll start, sir. Murugadan, sir. Rashikar.
I am ready.
Good evening. On behalf of EPI and other organizations, I heartily welcome one and all for this World Tuberculosis Day virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. On this occasion, I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore. I also welcome our own faculty, Dr. Jayant Antani from Pune, who has joined. I welcome our guest of honor, Dr. Muruganathan, past Governor, ACP India Chapter, past Dean ICP, past President National API, who needs no introduction. I also welcome today's guest speaker, Dr. Ravindra Mehta, Senior Pulmonologist from Apollo Hospitals, Bangalore, a dynamic interventional pulmonologist, former faculty of State University of Brooklyn, New York, USA, a great academician who has more than 75 articles, review abstract, book chapters. I also welcome our Chief Moderator, Dr. Rashekar from Kumbakonam, a great teacher par excellence, a great academician with up-to-date review of scientific contents and sharing the knowledge to all physicians all over the country. Held many positions in National API and other organizations, a great and humble man liked by all in the academics. Received many awards, IMA, Rotary Professional Excellence Award from Mary John, USA. I also invite our panelist, Dr. Sanjay Pujari, Director of Infectious Disease Hospital from Pune, who is also an ICMR task force member for COVID-19, a faculty on HIV medicine from University of USA, with many publications to his credit. I also welcome our other panelist, Dr. Nagarjuna Mattur, head of Pulmonology, Yashoda Hospital, Somajiguda, Hyderabad, with a special interest in EBUS and other interventions, with many publications both nationally and internationally. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service in the past, anticipating the third wave surge coming down gradually. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize the time by hearing an exchange of knowledge with them in their respective specialty. As I can see, more than 100 delegates who have registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. That speaks the powerful of the speakers at their specialty. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampada.
Yeah, now we are virtually honoring all the faculties for their tremendous work done in their specialty in the country. Now we play a short video on tuberculosis. Now I request Dr. Muruganathan sir, our guest of honor, to address the gathering. Over to you, sir.
Thank you, Dr. Sangram brother. In fact, I'm very happy to be the guest of honor to talk to you all about tuberculosis. In fact, I'm very happy to see a lot of awareness that is going on about the tuberculosis prevention. During the COVID times, this prevention of TB, the awareness of TB had taken a backseat. Though we had precautionary measures for COVID, which is also good for preventing tuberculosis, like mask, distance, hygiene, etc. There were a lot of cases compared to the previous years. You know, the World TB Day is celebrated because Robert Koch found out this bacilli in 1882. And we started in 1982, the first World TB Day. The current theme is invest to end TB and save lives. Having said that, how many of us take extra time to talk to patients and then help them to understand what tuberculosis is? So I request all of you who are attending, your role as a physician in prevention is very, very important. If somebody comes to you with a cough for more than 3 weeks, you should definitely investigate and rule out tuberculosis in this country, in our country. Same way, all diabetics, HIV patients are more prone to develop tuberculosis. The other way, because myself and Vijay Viswanathan had done a work on this, all tuberculosis patients, if you screen at one stage or other, they have diabetes. So one good message to all of you, screen for diabetes in TB patients and then screen TB for in diabetic patients. Same applies in HIV also. But unfortunately, this doesn't happen. In a small periphery tuberculosis chemotherapy center, they don't have facility to diagnose and screen diabetes. One problem with tuberculosis is we must have all the latest investigations can be done in every corner of the country. GeneXpert or culture or PCR, all that should be done. And the good thing what COVID has given to us and taught us is mask. This mask is very helpful in preventing diabetes, sorry, in preventing tuberculosis. Tuberculosis, you will have to give treatment very good. Tuberculosis, you must tell the patients they should take at least 6 months. And many patients, even including the educated persons, they take treatment for 2 months and they stop. It results in partial treated tuberculosis and recurrence, reactivation, and things like that. Once the tuberculosis becomes resistant, we don't have many drugs to treat resistant tuberculosis. In ordinary tuberculosis, we can treat with 2 months of intensive therapy and 4 months of passive therapy. So 6 months, the treatment is over. But if you are not very careful and advise the patient, and if they miss the treatment partially, then it becomes a problem. And as I said, diabetes precipitates and leads to resistant tuberculosis. So the message to all of you is, if somebody has got diabetes, screen for TB. About 4 months back, I came across one of my best doctor friend who was diabetic. He did not screen for tuberculosis and he was admitted with hemoptysis. So unless you have that eye, what mind doesn't know, eyes cannot see. So you will have to take care. Even in children, the BCG vaccination, the periodical testing, Mantoux test, all that, we were practicing those days. Now, how far this is followed, we don't know. The hygiene is very important. The environment is important. The pollution is another problem. And when somebody has got cough, we'll have to do the investigation. I'm sorry, I'm taking a little extra time. I'm borrowing the Sankar's time also, because Sankar is not there. So I'll have to cover Sankar, because if Sankar comes, he'll talk about all about the history. And one of the things in those days, if you see, the treatment for tuberculosis was exposure to sun. Even now we have that hospital photograph. All the patients in the sanatorium, they'll be kept outside the hospital line, and then there'll be direct sunlight. And that direct sunlight was supposed to cure or control tuberculosis, which means vitamin D has got some role. That's what they were thinking. So you have to consider all that. And then more important is research. We don't have the new drugs as we have new drugs for HIV. Same old drugs we are doing. And then only Bidaquine was now started, and some of the drugs which have got a lot of side effects. Tuberculosis not only affects the lungs, it affects the extrapulmonary manifestations, even in the bone, in the brain. So all those things, you must know. And as a physician, as a practitioner, one should know all forms of tuberculosis, and we must be ready, prepared to do the full treatment. And you should also know the drug treatment. And the drug treatment is very important, because there are a lot of interactions between rifamycin, INH, with anti-diabetic drugs, hypertensive drugs, and things like that. And the diet part, very important. A tuberculosis patient, when he loses weight, proper nutrition, proper proteins should be given. So comprehensive treatment, comprehensive approach, including the environment, air, all that is very important. And we have really accomplished a lot of things in tuberculosis management, but still we have got a long way to go. And in 2025, people are very optimistic that they will control the TB in all over the world. That is why this year the theme is invest to end TB and save lives. So ladies and gentlemen, my congratulations and message to all of you is, if you treat one TB patient, you are preventing spread of so many to so many people. And TB is a notifiable disease. And suppose if you come across a TB patient, and if you inform the government that the so-and-so has got tuberculosis, which is not against ethics, you will be also given 500 rupees. Not only you, even the lab technician who is doing sputum AFB, if he confirms and sends to the government, they get 500 rupees as an incentive. And somebody completes 6 months of treatment, full treatment, again, they are given 500 rupees. Why I am giving this message is, it is a notifiable disease. Don't shirk the responsibility. If somebody comes, for example, Rajshekar gets a case in Kumbakonam, he has to inform the JD or the nearby prayer medical center that so-and-so has TB, and it is not against ethics, and must make sure he does sputum AFB and takes the treatment. And many people, they take treatment for a week. That is why government makes sure they are giving full treatment. Now we don't follow the dots therapy, we give full therapy. So these are the updates and informations which one should share. I request Rajshekar to give the pearls about tuberculosis tomorrow in the WhatsApp group, as well as in our MediNews letter. We periodically release MediBeats newsletter. This newsletter, which we are released to yesterday, contain all the informations about tuberculosis and what is abdominal tuberculosis. Everything is there. And tomorrow also we are having a debate whether the Mantoux test is useful. Is it the golden test or the silver test or the bronze test? There's a debate. I'll be moderating that. So you please join that group also. Suresh Infection, who my good friend, is organizing in Chennai. It's a hybrid meeting. Those of you who are in Chennai, they can come directly to Green Park, or you can listen through virtually. So all of us have moral responsibility, and together we'll have to control tuberculosis, and then defeat TB. Thank you for giving me the opportunity. Over to you, Sangaram.
Thank you, sir, for your words of wisdom. Now we move on to the scientific session. Now I request Dr. Ravindra Mehta to address on the topic, a comprehensive approach to tracheobronchial tuberculosis and its complication. And I request our moderator, Dr. Rashekar, to take over further proceedings. As already Dr. Ravi Mehta is introduced, we'll straight away go to the topic. Later on, we'll have the panel discussions, questions. I request all to post the questions in the chat box. Over to Dr. Ravindra Mehta.
Hi everybody, today we're going to discuss a very out-of-the-box topic on this occasion of World TB Day, and the topic is titled A Comprehensive Approach to Tracheobronchial TB and Its Complications, and the term which I'm introducing, the chemo-mechanical partnership, which we'll justify later in the talk. What is the background for this particular discussion? Why are we going off the beaten path? Why are we not just taking up a whole bunch of drugs, new guidelines, and educating you? Idea is to get us thinking. Is there a whole segment of tuberculosis which needs looking at from a fresh angle, and no better occasion than World TB Day to highlight such a paradigm. So fresh off the press, a wake-up call, this editorial in this article in the Lancet by a leading TB researchers, including Dr. Udvadia, a friend who sent it over, tells us that by and large, the two pandemics of COVID-19 and tuberculosis, and they use this lovely, interesting term called intersecting pandemics, have led to issues on both fronts, and tuberculosis unfortunately got relegated to the background, which is going to be the problem in the next few months, 2 years for us to tackle. But what is the focus of this article or many such articles? It's all about detection, early diagnosis, appropriate treatment, and follow-up. In short, treading the known path, going on what has to be done and highlighting that to all of us. Now, what we have to realize that all this has very little on complications. Even the WHO articles which come have now finally acknowledged the fact that elective partial lung resection surgeries can be considered. They're left shifting the approach. But there is very, very little data on TB complications and its management. And as we treat TB more, as the numbers rise, certainly this is an important part of the spectrum. And not only that, some of them kill quickly, kill rapidly, and have a quality of life and healthcare utilization issue, which is major in most parts of the world where TB is so prevalent. So today, the talk is dedicated for this underserved and this less addressed patient group. No better occasion than World TB Day to pick up something which is important and bring it in front of a august group such as this one. And we talk of a different paradigm. What is this paradigm? What are we discussing? We're going to talk of things like airway involvement, which is by and large endobronchial tuberculosis, and the dreaded entity of TB bronchostenosis. We'll walk over and talk of prolonged air leak, which is the BPF you know about, massive hemoptysis, which kills them so acutely and so sadly, and discuss some out-of-the-box approaches for MDR TB. So endobronchial TB, as you all know, is proven TB of the tracheobronchial tree. It may be either a stenotic phenomena simulating an airway stenosis, such as a foreign body, or simulating asthma. And many TB bronchostenosis has been treated with inhalers like asthma. It unfortunately comes late after anti-TB treatment. So those people feel they're doing better, but they're actually losing lung, which is often missed by both patient and provider. And this is when you have sequelae, when it's a little too late, when the horse has fled the barn, is when you get bronchiectasis, which is unfortunately often not reversible. What are the types over there? It's either the fibrostenotic type, which is the sequelae part of it, healed lesion, which leads to all this. And this is more or less the acute type, which still has a scope to treat because these things can be treated with both antituberculous therapy and also steroids. Treatment options, antituberculous therapy may control infection, but please note, ladies and gentlemen, it will not prevent residual stenosis. Sequelae is a different ballgame. In the acute stage, as we said, you can give steroids for all the inflammatory and caseating types with the anti-TB treatment, but it will not work for the fibrostenotic type, which is unfortunately a scar process. And you know that when a scar forms in the body, it leaves its own mark. This is where we have to go more aggressive. This is where the chemo part goes to the mechanical part, as I talked about. And this is where you need some sort of mechanical thing, traditionally surgery. And in modern times with interventional pulmonologists, we have my colleague Nagarjun here also, where all these things can be done. Laser, electrocautery, balloon dilatation, stent placement. Understand that it's a very complex disease. India is both blessed because of the disease spectrum and cursed because of such complex diseases, because there's such terrific bronchomalacia, which makes treatment so very complex. And this is a situation where you have to know the science and also thinking of putting stents, which are either silicone or metal stents. And in this particular paradigm, now that we're shifting gears and enlightening you on that, some papers came out of Korea 2006 where they used silicone stents over there. And they showed that around 65%, 2/3 of patients could benefit, but 1/3 of patients had persistent stents over there. So 2/3 of patients, as against none, may benefit with this sort of therapy. And they went on to make an own stent of theirs because Western stents are quite expensive. They called it the natural stent or the natural Y stent, and they had a reasonable success rate. However, many issues because this was a new science in an area which was so challenging and so down the line. And so most of the work done so far for this important complication of tuberculosis is extrapolated from some other science such as benign tracheal stenosis, but needs its own attention, which has been woefully inadequate in the last 3 or 4 decades. Now, am I making sense? I can only actually make sense if I show you a good case. And look at this particular case, a young lady, and unfortunately this happens in young ladies, TB a year back, took ATT for 9 months, has wheezing and treated as asthma. Finally, people realize that there is more to this. She has a CT scan showing tight right main bronchial stenosis. 6 dilatations done, ladies and gentlemen, 6 dilatations done. So TB is gone, but TB is still there in terms of its sequelae. She comes to us after that. She's fed up of life because things are very difficult. We do an X-ray. You can see how she's losing the right lung. You can see infiltrates and possible bronchiectasis. You can see the tiny right main bronchus and an overactive left main bronchus. But you can see that there is malacia here, but it is open. So all the features what I talked about are shown here. Lung volume is getting lost as we speak. We can see bronchiectasis. We can see the other lung working too much. And we can see how there is malacia, bronchomalacia, as we talked about. One video is worth 1,000,000 words, and you can see here how we put a bronchoscope in. And ultimately, we saw bronchomalacia, a narrow trachea, and most worrisome, a right main bronchus, which was so stenosed that after 6 dilatations, nothing was working. We went ahead and did some careful thinking, offered 1 more dilatation, and lo and behold, a foreshortened but open airway. And this is where we went out of the box. Fresh come to India years ago were these stents, and we went ahead and then put one of these stents over there. Sorry, the videos are jumping. And we put a silicone stent out there to bridge the gap of the stenosis so as to give this young lady her life back. And you can see at the end of it, we have this little stenosis here, and the silicone stent which has come has done a very lovely job in terms of bridging the whole area. You can see how we're opening up this stent over here. And this stent does a great job in opening the right main bronchus after the 7th dilatation. Don't forget, this was the 7th dilatation. You can see the stent, and nicely the distal airway is open. So this was a silicone stent placed for this particular indication. How did she do? She did well. In 3 to 6 months, we usually try to take these stents out. They're not forever. We took it out, and 7-year follow-up, she's been okay. What has she been left with? Some malacia. But by and large, after 7 procedures, dilatation, she has an open airway. More interestingly, the bronchiectasis got better, didn't disappear, but got better. The remaining lung got saved, functional capacity improved, infection came down to the point that this lady declared infertile, conceived after many years, and she is doing well. So what does this case show us? That this is an out-of-the-box paradigm so far ignored in India, which can actually be done to make a difference. Another case to demonstrate the same issues, a 21-year-old male. See all these young people. Again, with stridor, you can see the trachea narrowed on the X-ray over here. He went to a surgeon. Surgeon did tracheal reconstruction out there. Unfortunately, 2 to 3% of these people post-reconstruction will fail. He had recurrent stridor, came back to us. Same thing, horrible airway. Imagining living with such an airway, trachea badly stenosed, This is a rigid bronchoscope. This is a balloon going in, similar to cardiology, similar to GI. We have another balloons over here. This balloon was used to open the airway. And because it is a complex stenosis post-surgery, a stent was put, the same silicone stent, to bridge this area so as to give this young man his life back, ultimately understanding that we have to remove the stent. This is a retention stitch which to make sure the stent doesn't fall down. So this is another case showing you TB sequelae, very dangerous, went through multiple procedures, went through surgery, and ultimately still had to go through his rigors to try and make a difference to his life. So this is a paradigm based on airway stenosis. We said we'll talk of more stuff. Let's take the whole gamut and introduce everything to you guys. Tuberculosis and bronchopleural fistula. Now here is where initially a lot of these fistulae used to be spontaneous, but now with more surgery happening, post-procedural bronchopleural fistula is reported also around post 6% in one series and can be catastrophic. Infection, superinfection, healing, nutrition, ultimately they carry their chest tube and they carry their chest tube to the grave. This is what happens. They don't do well. Surgeons try to do their job, put a whole bunch of flaps. Expertise is getting better, but still a long way to go. And then comes the fact that if we have done so much in the endobronchial area, can we do something to help these patients like we showed you in the last few cases of stenosis? And that is where there was a tinge in literature where the Japanese said that maybe you could put a blocker. You could block that particular leaking area, seal it off, and facilitate healing. We borrowed on that, and there's a whole bunch of cases which we then could work on. And we published our own experience where we invented our own blocker. We've called it the CESB, Customized Endobronchial Silicone Blocker, cheap and easily made so that we could help our patients. And this was published in a series in the Journal of Bronchology, where 5 patients out of the 31 overall were tuberculosis. Do we have cases on this? Yes, of course. See this 26-year-old gentleman. None of our patients are old over here. Sputum positive TB, the lung has a fistula now, hydropneumothorax, chest tube out there, losing weight, 2.5 months over, AFB negative. So TB is gone. But you can see the sequelae, horrible lung out here, horrible lung, air fluid level, everything really in a bad situation, very little good lung left. Options, take off the left lung. He's not willing, he's a young fellow. More problems, bad pseudomonas, poor nutrition, thoracoplasty, yeah, but he's not keen and it's the last option. What did we do at that point? Well, we had a lot of discussion. We had an interdisciplinary meeting with the surgeon. We went ahead and did a bronchoscopy to see if there's anything we can do endobronchially. As we went inside, you don't need to be a pulmonologist for this. You can see that we're exploring the bronchi, and lo and behold, one bronchus, there's a big hole over there, and that hole leads to the pleura. I will pause here to tell you that through the bronchus, we're seeing the pleural cavity. It's a peek into the pleura through the bronchus over there. Because of the big fistula, there is infection out there, there is pus over there. At the same time, you can see the chest tube. Then we said, okay, let's do something more. The same blocker we used and we put it inside over there to block it off. So the same customized silicone blocker was put there to block off that hole so as to seal everything and promote healing and get rid of infection. Then we went from the pleural side also and made sure that the hole was blocked by putting saline. So dual cavity confirmation of a fistula being sealed off to promote healing and give this man his infection control, leading to nutrition, his life back. Did it work? Well, the chest tube came out, which he was very happy about. And look at this remarkable improvement. The X-ray improved a little in the beginning, and then he followed up with us. And I have a fortune, I have been lucky to show you a 4-year CT. 4 years later, ladies and gentlemen, the lung we gave up on is actually back. You can see much of it lung has come back. God bless nature, thanks to conservative, minimally invasive therapy. And this man is leading a productive life, doing his job. So this was the art of bronchopleural fistula, the science of bronchopleural fistula, and the art of trying to treat it with out-of-the-box measures. What about hemoptysis? We all have seen it. From general practitioner to physician, everybody has seen a hemoptysis in TB, the famous Rasmussen aneurysm. What do we see in that? We see them coming in life-threatening situations. We try to do bronchial artery embolization. Emergency surgery is hardly possible. If this is not possible or fails, again, do we have some new options out there, which is the theme of today's talk? and we will enlighten you on these. Let's see some cases out here. A 50-year-old with COPD, blood pressure, and TB in the recent past comes with life-threatening hemoptysis, has left upper lobe and lingular bronchiectasis. So he must have been one of those who escaped proper therapy and has led to sequelae, or he came too late, whichever. And there you can see the scan over here showing this bronchiectasis over there. And then we went ahead and did an emergent bronchoscopy to find out what's going on. And in this bronchoscopy, all we saw was blood, blood, and blood. The traces of blood started over there. We could see over there inside it was all packing the left main bronchus. And the worry is, can you even suction this because it's overflowing also over here? And will you open up Pandora's box and put this gentleman in a worse situation? So at that point, we decided emergently, let's get some control. And to come back to the case over here, we said, let's block this bronchus off. If we block it off, then we can at least prevent spillage into the other area. Emergently, we use BioGlue over there. And this video will show you the entire paradigm of BioGlue injection, where this catheter through the bronchoscope is pushing in glue. The glue stays from 3 to 8 days. It's a temporizing measure, but gives you time to do other stuff, whether you want to do conservative therapy, bronchial artery embolization, and so on. So typically what happened was that this glue gave us time. We did the bronchial artery embolization, and we could not succeed in that because there was no feeding vessel. However, the glue bought us enough time to give antibiotics and supportive therapy, and the patient did not recover. So temporizing measure. We should not walk out with a message that all patients should be treated with glue, but one modality is available to buy us time in these acute situations requiring just a setup with a reasonably skilled bronchoscopist. What if it gets more complex? Look at this 52-year-old with tuberculosis out here who now has massive hemoptysis of 1 liter, a bad X-ray, attempted BAE and transferred to us because BAE did not work. There was no vessel, they could not do anything. This patient is crashing. He's already intubated, as you see over here. There is a whole bunch of clot over there. Large, you can see the vasculature, however, not amenable to BAE, despite what you think may be an aneurysm. The next bleed could be fatal. What do we do out there? Should we repeat a BAE? But that's not easy because it was not successful by a good operator. Do we try bronchoscopy? Again, the theme of trying to show you out of the box stuff. In this, we went ahead and then did the bronch, and you can see horrible right side massive clot out there. Again, the question of how to approach this. This time we used the same blocker. We made a blocker to try and block off the area which was bleeding so that we can at least prevent the blood from hitting the rest of the lung and save this gentleman's life till we can figure out what else to do. So you can see here, there's a blocker which was put in the right upper lobe, that customized blocker which we showed you a picture of, so as to buy us time, prepared at the bedside. This bought us time. We could stabilize the patient. Antibiotics were given, supportive care was given. 6 weeks later, the blocker was removed and he resumed his normal life. We published this experience also, and 13 cases were published in a peer-reviewed journal called Innovations, because they like innovations. And this was something which has helped us a lot when other modalities are not working. What about MDR, XDR, TB? We know that the whole change has been with drugs like bedaquiline coming and delamanid in the rest of the world, shorter regimens, how to do this, and so on. And now it's getting better and better. However, MDR, TB, 70-75%, XDR, 30 to 50%, we have not improved. So should we just be happy with medications, or is it time to say that, okay, more can be done? It is not only the fact that we as pulmonologists or you as physicians will only give this stuff. Can we use multimodality therapy? Interestingly, the impetus came from abroad. And that is where they said that if you use the old principles of thoracoplasty, which was done in the past for bad TB, or what's called plumbage, where they collapse the lung, an artificial pneumothorax, but if you do it from inside by putting blockers or valves, can you achieve the same thing? Similar to paradigms used in lung volume reduction for emphysema. So in such a situation, a paper came 3-4 years ago, and one more again in the International Journal of TB and Lung Disease, where they prepared a small blocker. It's actually like a small Heimlich valve, and they used it for patients who had MDR TB destructive therapy, destructive disease on therapy for 12 to 24 months, added this valve, blocking it over there, making the area hypoxemic, adding to therapy by making the whole area acidic also, so that the tuberculosis bacillus doesn't thrive. And there they found that these valves added to regular therapy improved success rates for bacterial conversion from 38 to 96%, cavity closure 21 to 67%, with a much higher closure rate than the control group, literally double. So this again was reflected in the endobronchial valves. We don't have this in India, but instead of that particular thing which we showed you, they've used standard endobronchial valves. And again, a case series where they used it for the stuff to treat MDRs and got reasonable success rate, and concluded that they're useful adjuncts in therapeutically difficult patients. These pictures show you that. You can see this particular case where they had you can see these cavities. 6 months after implantation, you can see how this cavity is now closing. And similar results are seen in this other case also, where cavity size is coming down. This is the valve not yet marketed in India, but those other things can be figured out. Somehow this has not picked up a lot. It's very provocative science, and we've been watching it for a while, but we feel that the time has come that all these things need to be looked at. And this is the occasion we bring it out in a public forum to try and talk about it again. So to summarize the whole talk, we've gone through a lot of details. We started with World TB, so you must have expected a whole bunch of medications. We shifted the paradigm by saying more needs to be done. We alerted you to the fact that this can be done. We've shown you these cases in our country, and we also mentioned that this can be done in our country. We've also told you about the young age of these patients. So we leave you with this take-home message. Tracheobronchial TB is a strongly medical disease with procedural new options for complications, which can be devastating, lethal, and debilitating to patients. We talked of TB, endobronchial tuberculosis, and its most horrible complication, TB bronchostenosis, where interdisciplinary management, including medications, going on to bronchoscopy, possible surgery, and interdisciplinary care, as we talked about repeatedly, can make a big difference. We now introduce a term which is not new but can be reiterated, a multimodality and interdisciplinary concept, not only bronchoscopy and surgery, but a chemomechanical, where medications with appropriate interventions done will probably give better outcome than medications alone. These pathways are being explored, and these pathways are evident in the cases we have shown you. This also can be extended to bronchopleural fistula, where medications don't do anything at all. Hemoptysis, where in urgent situations you need to do some procedure or the other most often, and bronchoscopy is an add-on procedure. And the new world of MDR, XDR, TB, where can we think of adding on some of these things to the new drugs which have come. Understand that the drugs have taken years to come. So can we think of the same paradigms in combination therapy with both chemotherapy and mechanical management to make a difference? I end with an interesting thought. Though much water has flown under the TB bridge, we know how difficult it is to treat TB in India and in rural India. We all need to think differently, an all-inclusive approach where A, we realize the limitations of current management, we embrace new therapy with medications, but we also look at other issues which are there in these patients and detect them proactively, use available modalities such as bronchoscopy, surgery, bronchial artery embolization, and we have enough skill and expertise in this lovely country, and understand that change is the only constant. And if we look at all disease with change, we can probably make a much better and more profound impact in the care of our patients. I'd like to end with a funny cartoon. Advances in our field, not only in medications, but both in procedurology, can change the course of patients. Conventional care is with medications. Newer approach ultimately get the job done to make patient care better. And I leave you with the term I started off with. It is time to think of the chemo, mechanical, multimodality, comprehensive, panoramic approach to patient care like never seen before. So post-COVID, we treat our patients with full enthusiasm and knowledge in a paradigm as we have outlined. Of course, knowledge curves are going up. We have knowledge, we have expertise, but we are still in our childhood. And the idea is to take this science ahead so as to deliver better in this complex disease. We end our talk with this positive note. The story will continue to evolve and more talks will be taken by people like us, Dr. Nagarjun and many others. Thank you very much for the attention and hope this has been engaging enough. I thank Dr. Sangram Biradar again, who has called us to take this talk. And I hope this sets the stage for a paradigm shift in our thinking process to take better care of our patients. Thank you very much.
Thank you, Dr. Ravindra Mehta. It was an excellent, thought-provoking lecture. Now I request Dr. R. Rajshekhar for the further proceedings. And I request Dr. Nagarjun Mattur and Dr. Sanjay Pujari, if he is there, to join for the panel discussion. Over to you, Dr. Rajshekhar, sir.
Thank you, Dr. Sangaram Peradar, for the nice arrangement. And I am very much thankful, Dr. Ravindra Mehta, for the crisp presentation. Just to highlight the World TB Day, the very important thing, we must define the management of tuberculosis. First is early diagnosis. Second, initiate multi-drug therapy. Third, prevent the emergency of drug resistance. And last but not least is prevention of spread in the community. And we all know tuberculosis is a multi-system disease with varied presentation worldwide. It is less in developed countries, but more common in developing and underdeveloped countries. And we all know it is, one is pulmonary and another involvement is extrapulmonary. So regarding the tracheobronchial tuberculosis is a very varied presentation. So the problem is the tracheobronchial tuberculosis, it spreads approximately about 10 to 39% of the patients with the pulmonary tuberculosis. That is the point to be noted. So it is the tubercle infection of the trachea and bronchi. That is tracheobronchial tuberculosis. The problem is the patients may have insidious onset, non-specific presentation. So insidious onset, the chest X-ray may be normal 10 to 20%. That is why sputum positive, chest X-ray negative, that is most likely endobronchial tuberculosis. We must keep it in mind. The bronchoscopy is the most definite method of diagnosis which provides adequate specimens for microbiological and histopathological diagnosis. So tracheobronchial tuberculosis is very common. The commonest complication is tracheobronchial stenosis, which our Dr. Ravindra Mehta has highlighted. And about 90% of patients with the tracheobronchial tuberculosis have some degree of tracheal and bronchial stenosis. Let me invite my panelists also to highlight. We will go by the so many discussion also. And what is multi-drug therapy? What is, he has highlighted bedaquiline. And also there are so many drugs. There are so many newer drugs. That is another drug is Delaminate, another newer drug. So we will highlight on those drugs. So I invite the panelist, Dr. Nagarjuna Mathura, please come and say a few words. Nagarjuna and Sanjay Pujari, are you there? Yes, he is there. Yeah, please.
Yeah. At the outset, I'd like to thank Dr. Sangaram sir for giving me this opportunity to be the panelist here. And it was, as expected, a wonderful lecture on airway complications of tuberculosis by Dr. Ravi Mehta sir. So to start off and share our experience also, as has been said, I think tracheobronchial tuberculosis, the point of discussion for today, is probably one of the most dreaded complications we see. And from our experience, usually for reasons unclear, we usually see it, this stenotic form of tuberculosis in young ladies. Usually in between 20 to 40 years, debilitated people are the ones who come with this tracheobronchial stenosis. As Dr. Ravi Mehta sir has also showed in a couple of his cases had right main and trachea, but in our experience, left main seems to be the commonest site of involvement of tracheobronchial tuberculosis. Why it affects only a couple of them and not others is still something which we're not very clear, but definitely early diagnosis and intervention will help save the lung. If we don't diagnose early, we'll usually end up losing the lung also. So I think this is one form of tuberculosis where we should have a high element of suspicion and then diagnose early and intervene early.
Yeah, Dr. Rajshekhar sir.
Yeah, Another panelist is he there?
Yeah, no, Sanjay Pujari is held up in another talk. He is giving in
Okay.
another talk.
Sir,
Ravi Mehta is there?
there is a question. How to diagnose abdominal tuberculosis? Dr. Ravindra Mehta.
I think Dr. Nagarjuna can take. Ravindra Mehta he is also getting connected.
Okay.
Hmm.
Nagarjuna.
Yes, abdominal TB basically, see, it depends on the type of presentation. If the person presents with ascites, then definitely ascitic fluid analysis should be the first investigation of choice. If it's an exudative fluid with an AD of somewhere around more than 32 is considered probably diagnostic. Then the radiology will definitely help. The site of lesion, the site of involvement, ileocecal involvement, and so on and so forth, peritoneal nodules, all of them will help in diagnosing. And to some extent, the interventions, colonoscopy and ileocecal ileal biopsies also many times people do. A lot of confusion always between Crohn's and tuberculosis, and that is where the role of the newer molecular markers. As far as ascitic fluid is concerned, the role of this expert is not very good. But if we talk about biopsies, if we do a biopsy of the ileocecal region, colon, or a lymph nodal biopsy from the abdomen, on the tissues, the sensitivity of gene expert is it's reasonably good. So basically, abdominal TB, more of you have to go by the radiological presentation, analysis of ascitic fluid, and whenever we have a biopsy, we can try to look for either presence of granulomas or the presence of the bacilli, either in its true form or the genes of the bacilli, which can be detected by the molecular assays. If we are hitting a dead end, then always comes the role of diagnostic laparoscopy, where you directly go inside, look at the peritoneum, take a biopsy, and we have had cases where we have diagnosed peritoneal TB on laparoscopic biopsies also. So it is not one single presentation. Abdominal TB itself is a plethora of manifestations. So depending upon how the patient presents, you have to go and get a diagnosis.
Another important thing is mesenteric lymph nodes. So we must examine the lymph nodes and if necessary, take a biopsy.
Correct.
And the exact pathogenesis of tracheobronchial tuberculosis is yet to be understood. There are about 4 mechanisms, proposed mechanism. Even way back in 1951, SMART has highlighted about the pathophysiology. The first one is direct spread of tubercle bacillus from the parenchymal tuberculosis or cavitator lesions containing the abundant tubercle bacilli. Number 2, dissemination of tubercle bacilli from peribronchial lymph nodes and also the channels that is draining the pulmonary parenchymal tuberculosis. So this is being supported by a very important finding, the so-called endobronchial biopsy on the patients. So it shows the intact mucosa, but submucosal involvement is very much noted. And third point, there is a spread from contagious mediastinal lymph node to the bronchial mucosa, but occasionally resulting in bronchonodal fistula. What Dr. Nagarjuna Mathur? There is also, that's very important, is the bronchonodal fistula. This mode of infection is particularly known to affect especially the pediatric population. That is why the pediatric population is slightly different in the chest X-ray also. That is the interlobar fissure thickening. The interlobar fissure thickening, minor interlobar fissure and major interlobar fissure, we all know. The interlobar fissure thickening is significant primary complex in children, but not. It is very much diagnostic in adults because naturally as age advances, there is interlobar fissure thickening. And another thing is, last but not least, is direct implantation of inhaled Mycobacterium tuberculosis into the bronchial wall mucosa. These are the 4 pathophysiological mechanisms of tracheobronchial tuberculosis. And also it can be clinically divided into active disease, that is by the bronchoscopic findings of active caseating material, ulceration or granulation tissue formation, or histological findings of caseating necrosis or a positive tubercle bacilli on culture. Usually we don't do a culture. Usually we do a Matto test, we do other advanced test and all. But we don't do a culture as a routine mechanism. But in tracheobronchial, better to do, and especially to do a bronchoscopy and also biopsy. So during the healing phase of active endobronchial tuberculosis, the cicatrization can cause mucosal ulceration, necrosis, fibrosis, so resulting in stenosis. So this is the important thing. So Ravi Mehta connection is bad. He is unable to
Yeah, he has
connect.
joined. He has joined.
Joined.
Yeah.
So Ravindra Mehta, what is your what's your view? Whether the left bronchial involvement is more or the right bronchial involvement is more?
No,
Nagarjuna.
Sir,
Mathur, you tell
I
me.
think there is still some connectivity issues with Dr. Ravi Mehta.
Oh, you tell me.
I
What
think
is
world
that?
over, I think it is the left main bronchus which is more commonly involved than the right main bronchus. And another, there are two things which are very peculiar for tracheobronchial stenosis. One, it is usually multi-level. So in this sense, usually we see a combination of an Apollo bronchus, the main bronchus, and the trachea getting involved in varying proportions. This is as opposed to a stenosis which we see after intubation or another diseases, which is usually a short segment single site. TB, tracheobronchial stenosis, is usually multi-level. Second unique thing is that there is usually a combination of malacia and stenosis. As in the video which was shown by Dr. Ravi Mehta also, this is a very common thing. The TB basically sort of destroys the cartilages and everything. So there are some areas which are malacic, some areas which are stenotic. And usually it's a combination of stenosis and malacia which is usually there. Though stenosis predominates, there are some cases which only have malacia also. So these are some unique things about tubercular tracheobronchostenosis vis-a-vis tracheobronchostenosis of other causes. So this is from our experience, but I don't think we have any official data which compared and looked at how things are different, because this is something which is more common in the developing part of the country world.
The left main bronchus, the left bronchial involvement is more common, as you rightly pointed out. The reason being, it is anatomically compressed by the aortic arch, very important, and the left mediastinal lymph node. So to get infected faster than the right-sided lymph nodes, resulting in increased vulnerability of the left main stem bronchus. That is very important to endobronchial infection of tracheobronchial tuberculosis. That is the main reason why the left main, because of the compression of aortic arch and the left main mediastinal lymph node. That is the important point.
Yeah,
And
Dr.
what
Ravi Mehta
about
has
the-
joined.
Yeah.
Dr. Ravi
What
Mehta has
about-
joined.
Yeah, Ravindra Mehta, what about the sex ratio, female versus males? What is your comment?
Yes, sir. Sorry, you just had some connectivity issues.
No
But
problem.
I think Nagarjuna has covered the point so well, and you have been given an excellent explanation of the pathophysiology. So this is a very unusual and very bad disease, because as we said, it creeps up on you. It comes at the later phase when you think that you are complacent with adequate TB therapy. It is undiagnosed because by and large, clinically we follow patients and radiology may not be so accurate. And as you pointed out, it affects anatomical parts which are very challenging to treat. And the sex predilection is more for females. Why is it females is very difficult to explain, and the various theories such as a takeoff of the left main bronchus being at an angle, you already mentioned the aortic arch, many such theories are there. The problem is that because it happens in these young females in this location, they tend to lose lung function very fast. And as Nagarjun pointed out, a multi-level stenosis with a late detection and loss of lung function with distal bronchiectasis is a devastating combination. So this is one of the major issues which we have to deal with as of this point. And we presume that this is much more common than we ever thought before. For example, it is quite possible that most of the TB bronchiectasis described in the past is actually distal small airway narrowing and stenosis, which led to bronchiectasis. So a much commoner disease than we imagine, debilitating, comes later, female predilection, younger age, and left main bronchus. Lots of food for thought, and much work needs to be done to try and both early diagnosis, appropriate therapy, figuring out disease versus malacia, and not actually just giving blind steroids and indefinite ATT, which is not the answer.
So in the chat box, how common pediatric tuberculosis, that is primary complex, how common it is primary complex? That is the question. Pediatric tuberculosis. Ravindra Mehta.
Not sure, sir. Not something we do on regular basis. So frankly, I don't think I'm the right person to answer this one.
Almost every child is diagnosed as a pediatric primary complex and they are put on anti-tubercular therapy. And another question is, how common is tuberculous orchitis and how will you confirm it? Tuberculous orchitis.
Again, I think it's not a common thing, but at the same time, I don't think we are the correct people to talk about specific organ tuberculosis. That should be confirmed by the urologist by ruling out other differentials, and that will fall into their perspective.
What's your advice of tuberculin skin test and interferon gamma release assay? The sensitivity and specificity.
So I think that's a very huge thing by itself. In India, at least, both of them, as most of us would already know, that it basically tests for latent tuberculosis. So the whole thing boils down to the fact whether you want to treat latent tuberculosis or not. In adults, at least, we don't diagnose any TB based upon active TB based on the presence of MAN2. So just because a MAN2 is positive or quantiferon TB gold is positive, we should not label the person as having tuberculosis. This is a very, very, very important thing which everyone has to understand. They only indicate to the bacilli and the fact that the person is mounting some sort of immune response to tuberculin antigens. That's all. Only when the person has clinico-radiological microbiological features of tuberculosis do we label them as active tuberculosis. So then why are these important? Only if there are certain clinical circumstances where you might want to treat a latent tuberculosis. So in low TB endemic countries, yes, treating latent tuberculosis also is important as their TB strategy. And in India also, as we move towards elimination of TB, the focus will shift towards treating latent TB infection also. And then other than that, the other clinical circumstances where we use these MAN2 or IGRA is differentiating tuberculosis from sarcoidosis. Again, that's a very common clinical problem. And sarcoid by definition is known to have MAN2 negativity. That is, they are known to have cutaneous energy to tuberculin. So when we are stuck up and if we do a MAN2 is strongly positive, then it is a point against sarcoidosis. So this is one situation where we use in clinical scenario.
That's where we do a Quames test.
Yes, and then the second thing is in certain clinical indications. For example, pre-transplant, you are planning for a transplant, and then some centers do this IGRA or MAN2 and then try to treat the latent TB so as to decrease the risk of TB reactivation post-transplant. Similarly, in when we want to start biologics, especially for Crohn's disease and others, other rheumatological conditions, for example, when they have to start on tofacitinib. So certain drugs which have a higher chance of making the TB reactivated, before starting those drugs, again, we do screen for latent TB infection. And then if it is found, we would want to treat latent tuberculosis infection. I think these are some of the clinical implications of tuberculin skin testing in adults. This is predominantly in adults is what I'm trying to talk. The third question which Sir had asked is MAN2 versus IGRA. Correct, sir?
Yeah.
Interferon gamma release assays. So basically you have two types of interferon gamma release assays. The TB gold is one of the thing, and the TB spot thing is another. The interferon gamma release, the TB gold is one which is commonly done. In fact, it is abused also. The difference is that it is more specific as compared to MAN2. So it doesn't have much cross reactivity with the BCG or the NTM infections. It is also more sensitive as compared to MAN2. These are the two things, but definitely it is a costly investigation. And I think that is about MAN2 versus IGRA. I think others can add on to what I have said.
There is a question. What is the incidence of latent tuberculosis infection? What is the treatment? How frequently ones need to follow up the treatment for the latent tuberculosis?
It is actually said that 40% of our Indian population have some sort of exposure to tuberculosis bacteria at some point in their life. So the prevalence, not incidence, prevalence of LTBA is around 40% in our country. That is precisely the reason why you're not supposed to use it for treatment in our country, at least at this point of time. Things will definitely change. What is the treatment? So you don't treat LTBA every time in India. Things may change as the incidence of TB comes down. So there are only certain specific scenarios, as I have mentioned, where you would want to treat LTBA. He's going to a country where there is low TB prevalence, or he is being planned for a transplant or for a medicine which is known to cause TB reactivation. These are certain scenarios where you would want to treat latent TB infection. Again, there are several treatment regimens which have been proposed. The single drug INH therapy, the combination of isoniazid and rifampicin for 3 months. So that is a different topic altogether. In India, however, I feel with the background resistance of isoniazid around 10 to 15%, isoniazid monotherapy probably should not be used, and we should probably use combination of isoniazid and rifampicin.
There is also a very recent article, adenosine deaminase activity in pulmonary tuberculosis, that is in sputum versus serum. But the sputum adenosine deaminase activity, that is ADA1 and ADA2, it is more significant than serum, but it requires further studies. It is published in the Egyptian Journal of Tuberculosis. Very recent article, adenosine deaminase activity in pulmonary tuberculosis. It is somewhat a valid report. Just to
I think
highlight.
at this point, if you have to pardon me, I would little disagree. There are definitely articles coming up, but then at this point of time, our message should not be that we recommend ADA in anything other than.
No, not necessarily. It requires further studies, but we
Yes.
must know what is going on in the
That's all.
world. That is very important. I never say it is a confirmatory test. It requires further to be evaluated.
Evaluated.
Even
See,
Mantoux
so-
test positivity itself is not a significant test.
Exactly. So
Even
in
it
fact,
can be negative in immunocompromised individual. It can be even pseudo-positive, pseudo-negative. So we must make everyone to know what is going on in and around us. That is very important. That is my carry-home message. What about the drugs, Dr. Speaker is there?
Dr.
Yeah, tell me, sir.
Mehta is there.
You have highlighted the corticosteroids very much, and also the silicon stent. And what about the drug regimen, the 4-drug regimen, especially the combination of bedaquiline you have told, and also proteomanid and linsolid? What's your comment on that? These 3 combinations, bedaquiline, proteomanid, and linsolid. That is the 6 months treatment. They have also highlighted.
So
Bedaquiline.
the WHO guidelines is what is there, and I showed a slide on that. And I think that is available everywhere. That is what everyone is following at this point.
Yeah.
Of course, things keep changing because of resistance. The latest statistics, as Nagarjun was saying, INH has come to 24%, they say, in India. It's very concerning things. Gradually, what we're seeing is a shift of the old paradigm. Either you give large number of drugs for long periods of time, or we're able to get our hands on bedaquiline and their shorter regimens, which has given the success rates up to 75% or so. So I think those standard regimens now are the way to go. Customized medicine happens only when they've received many prior medications. Then we get into issues such as what have they taken, what is left, what is the compliance issue, toxicity issue, and so on. So I think it is, fortunately, at least in the last.
Again, he has got a
Yeah, some connectivity issue are there, traveling, everybody is traveling.
Nagarjun Mathur, what's your advice about the rifampicin with the moxifloxacin? What's your advice, the combined therapy?
So I would say that I am still sticking to the conventional 4-drug regimen which is there in our country, but then lot of
INH, ethambutol, rifamycin, pyrazinamide. That's
at
the
this
convention.
point of time,
Okay.
yes. At this point of time, yes.
We must,
But then
yeah.
things are definitely going to change. Lot of new trials are going on all these molecule short-term therapies, but we should wait for more robust data. And I think that is what I will tell. For conventional drug
What about, yeah, tell me.
tuberculosis, we are still following the 4-drug regimen, which we have been following for the last years with good results.
That is where INH, rifamycin, ethambutol, and pyrazinamide. These are the
Yes.
standard treatment. What's your advice about another newer drug about 40 years back, delaminid?
So the problem with bedaquiline, see, bedaquiline and
Delaminid.
yeah, delaminate also, but the thing is, because we am corporate world, we do not have access to any of these medicines which are now being prescribed for drug-resistant tuberculosis. So I think if we have any person, then I think we usually refer to the government authorities who are dealing the MDR-TB, and they are the ones who start the medicines.
And kindly highlight about the pulmonary function test in tracheobronchial tuberculosis.
Sir, if we know that the person has tuberculosis, active tuberculosis, we don't do pulmonary function testing. The reason being, it itself leads to a lot of aerosolization of the bacteria, and there definitely everyone around him is going to get, because the person has to blow out forcefully. So in active tuberculosis, we don't do PFTs. So the role of PFT actually probably will come only when the person is healed of tuberculosis and left with sort of what is known as a fibrostenotic tuberculosis. Then if we do, definitely you're going to get an obstructive physiology, but then you will have a flattening of the inspiratory or the expiratory loop depending upon the site of obstruction. If you have an intrathoracic obstruction, you will have an expiratory flattening. If you have an extrathoracic obstruction, inspiratory flattening. But in our experience, most of the tuberculosis are in the lower 1/3 of trachea. So that is intrathoracic part. So usually you would usually get expiratory flattening. But as I have said, we usually avoid PFTs in all our patients of tuberculosis.
There is a question in chat box. Following treatment of pulmonary tuberculosis, there is a lung damage and treated with anti-tuberculosis therapy. When will you confirm totally cured, on what basis?
Correct. So I think this is a very, very practical thing. If you have a destroyed lung, then X-rays will continue to show the opacity. So how would you confirm that the person is cured or not? I think this is what the person, the one who the person wanted to ask. Then I think here we have to look at the whole clinical picture. Most important is the clinical symptoms, whether the person has been febrile with improvement in appetite and weight. Cough again can remain because TB sequelae also will have cough. So basically what we're trying to look at is fever, some weight gain and appetite gain as the constitutional improvement. Second, radiological clues. If you do a CT, there are certain pointers towards activity of the disease. Being thick, the cavities being thick walled, presence of lot of associated centilobular nodules, presence of consolidation, they all indicate that the disease might be probably still active. And if you only find a fibrotic scar, thin walled cavities, traction bronchiectasis, then it is all indicative of a TB sequelae. So second is the radiological observation. Sometimes X-ray may not be helpful. We can get a CT at the end of therapy to look at it. Suppose you're finding features suggestive of activity still left, then you can either try inducing the sputum to prove that it is AFB smear and culture negative. Again, you cannot use expert here because you cannot use gene expert to prove that he is cured. It is only for confirmation of diagnosis. The expert will remain positive for up to 2 years, and the expert ultra, which is the current one, which is being used, will remain positive for 7 years. So you only have to use smear and culture. You can either induce sputum or you can do a bronchoscopy and BAL from that particular area. to confirm that he's actually negative. These are the three things. And lastly, ESR also can be used to monitor. So if you have to decide whether a person with radiological opacities has been cured or not, you look at a combination of things. You look at the clinical improvement, you look at the radiological signs of activity, you try to confirm microbiologically whenever possible, and you also can to some extent depend upon laboratory markers like ESR. So these are the four things, and it is a holistic approach we have to take.
And Dr. Rangarajan is asking one question. That is
One more thing, sir. So I'll just finish off the question. This thing, there is one more new concept coming up: the utility of PET in
PET scan.
in deciding disease activity. You have a person with fibrotic lesions and you're not sure about it. So there is some data. It is not yet standardized, but use of a PET to decide on the disease activity. So if that fibrotic lesions are showing a lot of FDG uptake, probably you still have some activity left within that lesions. So this concept is being looked at both in sarcoid as well as in tuberculosis. So this is just one of the new things which is being coming up.
Sarcoidosis, we do a Quames test. Following treatment of pulmonary tuberculosis, that you have, how frequently you see in HIV diabetes associated with the tuberculosis? Is PZI, pyrazinamide E means available, and is it used?
1 second. So I think this HIV and diabetes was also mentioned by the speaker earlier. Also, the chairperson also has commented that definitely I think there are two things which have to be. It's a dual thing. If a person has tuberculosis, you screen for HIV, you screen for diabetes. Similarly, if a person is HIV, then irrespective of the duration of symptoms, you have to suspect TB always. Uncontrolled diabetes, again, yes, the more prone to have tuberculosis, more prone to have TB relapse, again, if the diabetes remains uncontrolled. And it is a vice versa thing. So you have to screen TB in diabetes, diabetics in TB, TB in HIV, HIV in diabetes.
Yeah, Dr. Rashekar sir, we have Dr. Sanjay Pujari. He is authority on HIV and tuberculosis.
Yeah.
Dr. Sanjay, your comment? Yeah.
Yes, so I don't know. I just joined. I'm really sorry. I had a talk somewhere else.
Yeah, no. The
what
question
is,
is, how frequently have you seen HIV, diabetes associated with tuberculosis?
You mean all the three together?
Yeah, that's what.
Yeah, so we have a paper on that, looking at in the Asian region, looking at HIV, TB, and diabetes. We have to remember that diabetes is an increasing problem in the HIV positive population as well. So these patients are aging, they are on long-standing antiretroviral treatment, and some of the ARV like boosted protease inhibitors are associated with diabetes. So the prevalence of diabetes in HIV infected individuals is high. The TB itself, there is a higher risk of active TB from latent TB progression to active TB in both these populations. And in our study, we could demonstrate that the risk of incident TB was higher in individuals with HIV plus diabetes as compared to HIV alone or diabetes alone. So I think it's an
please. The other thing is HIV and tuberculosis. Any specific newer guidelines for management which have come across?
Well, currently, there's no difference in the way we manage TB in the HIV context. The only issues are about using a concomitant antiretroviral treatment. And here now, when to start ART in the context of active TB, the data is quite clear that you need to start it as early as possible, as soon as our anti-TB drugs are tolerated. We try to maintain rifampicin, of course, in the regimen in spite of its drug-drug interactions. Only 2 drugs can be used in this context from the ARV class. So you can use efavirenz 600 milligram along with rifampicin, or you can use dolutegravir, but dolutegravir has to double the dose. So 50 milligram BD when you use concomitantly with rifampicin. And make sure that even after discontinuing your rifampicin-based TB treatment, you continue with the BID dolutegravir for at least 2 weeks, because the induction of liver enzymes by rifampicin continues for 2 weeks after discontinuation of rifampicin. So that is an important issue as well. And of course, I'm not sure whether this was discussed, but there is a lot of interest in shorter regimens. And now we have data from the TB practical study, which looks at BPAL moxifloxacin, 6 months for rifampicin resistant tuberculosis. And though these drugs are not available in India, this is game changing. And you would soon have this come into the WHO guidelines irrespective of the HIV status.
Dr. Rangarajan is asking, is PZI available and is it used? He means pyrazinamide. Dr. Nagarjun Mathur.
Next.
Yes. If pyrazinamide is available all over the countries.
Yeah, that's what PZI, yes, good. He means pyrazinamide only.
Dr. Sanjay, anything pertaining to COVID? Did you notice any changes in the management of tuberculosis, ART, and COVID?
Well, COVID overwhelmed our health systems, and I'm sure there is data globally from even the WHO's TB report, which shows that TB notifications fell down during COVID epidemic and TB mortality increased globally during the COVID epidemic. So we missed a lot of tuberculosis during the COVID epidemic. In the context of HIV, we actually also published similar presentation, patient presenting you with acute COVID-like picture, including inflammatory markers as well as CT scan, showing classical ground glassing opacities. But on bronchoalveolar lavages, these patients COVID-2 negative but AFB positive in the HIV context when the CD4 was low. So pulmonary TB was masquerading as COVID-19 in advanced HIV disease. So never forget PCPs or, when you're evaluating a COVID-19 patient. Of course, now COVID-19 is dramatically gone down, but this was what we faced during that time. When you are managing COVID and in the context of TB, you have to worry about interactions with rifampicin, with steroid, dexamethasone, which you use for COVID-19, or even remdesivir, which you may use for patients with low flow oxygen. So apart from that, there's not much, but I think we have missed quite a lot of TB during the COVID-19 pandemic.
Prior to fibrosis with head injury and causing convulsions and hemoptysis, how to manage?
Dr. Nagarjuna,
Yeah.
can you take?
No, I was just going through the questions. I think there are two different things here. Head injury and convulsions have to be managed as per the standard neurological protocols. The only problem here is hemoptysis. So hemoptysis is always a stepwise approach. I would say first is medical management. You try to suppress the cough, give antifibrinolytics like tranexamic acid, oral or IV, and then one broad spectrum antibiotic. If it is still not helping, the second thing which we would want to do is bronchial artery embolization, because in old TB scars, the most common cause of bleeders are the systemic vessels, the bronchial arteries. So the bronchial artery embolization will be the first therapy unless until you find Rasmussen's aneurysm, which is the pulmonary source. If that is also not helping, then comes the heroic approaches, which were discussed earlier also by Dr. Ravi Mehta sir. You can consider an endobronchial glue or a spigot insertion vis-a-vis a surgery. But in the context where he is having head injury and convulsing, I don't think we would go for surgery. Usually try to be conservative, medical management. If not helping, bronchial artery embolization. I think with this, 99% of the times you'll be able to control the bleed.
Yeah, Dr. Rashekar sir, there are no more questions,
Yeah.
I think.
No questions.
Yeah, we will have one more take-home message from each speaker and we'll close.
Yeah.
Yeah, Dr. Sanjay, your take-home message for the audience.
Dr. Sanjay.
Oh, I would really say that it's from the treatment perspective and even from the prevention or treatment of latent tuberculosis perspective, it's very exciting time in TB therapeutics. There are shorter regimens, very promising rifampicin-based regimens, even for kids, rifampicin-based short course regimen. So you would see moving towards a treatment approach where you would go away from a standard 6 months regimen for drug susceptible tuberculosis to tailoring it to level of disease, whether the patient has cavities, how much lung involvement, whether it's smear positive, smear negative, etc. So that is one. The second you may see is a rapid improvement in diagnostics. I mean, it's very exciting time. We have a lot of pipeline of even TB diagnosis happening without taking sputum or demonstrating AFB. We are looking at markers in the blood of immune response to active tuberculosis, RNA fragments, cytokine responses, etc., which is up and above IGRA, etc., that we are talking about, which really can't differentiate between latent and active tuberculosis in adults. So I think this is exciting time. Keep updated and try to, even for rifampicin resistant tuberculosis, things have been moving very fast and guidelines will come very fast, changing our entire approach in the few years at least, with the caveat that we need to have access to these drugs.
Yeah, thank you.
There is
Dr. Naga,
a-
yeah. Yeah.
1 minute. How will you treat tuberculosis of the skin? Cutaneous tuberculosis, he means.
Yeah, they are all pulmonary.
Right. It will affect every part of our body. He's asking, how do you manage?
Yeah, you go ahead, sir.
Dr. Nagarjan?
No, I think the recommendation would remain the same. Irrespective of the site of disease, the protocol will remain the same. And I think for skin tuberculosis, the duration also remains the same. That is the 6 months.
Exactly.
We have to deal TB skin any differently from how we are dealing TB of the other parts of the body.
Yeah, Dr. Rashekar, sir, your take home
Yeah.
message.
He means tuberculosis varicose skin, TBVC. Okay. So tracheobronchial tuberculosis presentation is very insidious, very difficult to diagnose. So early initiation of treatment, early initiation of diagnosis, treatment very important. If you are unable to diagnose, appropriate referral to appropriate person in appropriate time, that is very important. Better to refer to today's speaker or Nagarjun Mathur and early initiation of treatment, very, very important. Otherwise, they will develop tracheobronchial stenosis and land in trouble. Thank you.
Dr. Nagarjan, your take home message before
Yeah,
we
I think
conclude.
till that time, all the exciting things which Dr. Sanjay Pujari had spoken about will become reality in our country. I think we should stick to our basics, always suspect TB, diagnose as soon as possible with whatever modalities you have, start treatment using the current regimen which is there, and most importantly, ensure good compliance so that the person gets cured from tuberculosis. I think these are the basics which still hold true for 98% of the cases. 2% may be atypical cases, but we have to focus on the majority.
Ravi Mehta, you are there? I think he's not there.
Ravi Mehta is not there, sir.
Yeah. Sir, we will conclude. Dr. Rashekar?
Yeah, thank you. Thank you very much for inviting me to be a moderator, and thanks to the speaker, panelist, and Dr. Sangaram Birada for organizing this nice meet, and also my mentor, Dr. Muruganathan sir. And unfortunately, Dr. P.S. Shankar is unable to join. Thanks a lot to him, Dr. P.S. Shankar.
Yeah, and lastly, thank all the attendees who have joined from all over the place.
Yeah, please.
Yeah.
Thank you. Thank
Yeah,
you.
thank you, Dr. Nagar. Thank you, Dr.
Thank you so much.
Sanjay.
Thank you so
Yeah,
much.
thank
and
you,
bye.
thank you. Thank you.
Thank you.